Assalamu alaikum. We'll start our second session today about fracture risk assessment, and we have three speakers to talk about this. We'll start with Dr. Eugene Mccloskey. He's a professor in adult bone disease in academic unit bone metabolism in Millanabi Center for Musculoskeletal Research at the University of Sheffield.
Hello, my name is Eugene Mccloskey from the University of Sheffield, and it's an absolute privilege and honour to be able to participate in the Saudi Osteoporosis Symposium this year. I'm going to give three talks during the meeting, and the first one that I'll address this morning is on FRAX, the clinical uses of FRAX, the adjustments that we're making to FRAX, and future developments of the FRAX tool. These are my disclosures. FRAX has now been with us for almost 15 years, and the intended use of FRAX was to allow clinicians who were looking after many aspects of health to be able to focus in on bone health, to be able to assess fracture risk, and to be able then to make decisions about the need for treatment, and increasingly recently, not just about the need for treatment, but the type of treatment that should be. Osteoporosis, as we know, is a very common disease, so it's looked after in lots of clinical settings. In many countries, it falls very firmly within the realm of primary care. But in primary care, of course, the audience and the participants, healthcare professionals there, have got many diseases to look after. And FRAX is really trying to provide them with a level of expertise to enable good management of bone health. Why did we need FRAX? Well, you could say that we know how to assess bone health, bone strength, by the surrogate measurement of bone mineral density. And bone mineral density has been able to be measured for several decades now. But it was increasingly recognized that bone mineral density is really just one component of fracture risk. And this is a slide that many of you will have seen before. It's from the Surgeon General's workshop in 2002. And in the orange bars, we're looking at the fracture rate as the T-score. This is measured at the distal forearm. And as the T-score decreases, as it goes to the right, you can see that the fracture rate increases in a nice, steady fashion. So low BMD predicts future fracture rates and high fracture rates. But the vast majority of the population don't lie in the population with very low forearm BMD. They lie, as you might expect, around the average or just below the average for the population. And because there are more people in the population there, that's where we see the majority of fractures within the population. So that just said that we can use bone mineral density, but we need to be able to combine bone mineral density with other risk factors for assessing fracture risk. So we undertook a number of large meta-analyses that looked at various risk factors that subsequently came to be included in the FRAX model. And this slide is just looking at femoral neck BMD and the prediction of hip fractures across various ages. The green line shows the average gradient of risk, the average increase in risk per standard deviation decrease in femoral neck BMD. It sits around 2.8. However, you can see that that gradient of risk differs across the age bands, being higher at younger ages per standard deviation decrease in BMD than it is at older ages. And it's this sort of information that allows us to be a little bit more refined in our prediction of fracture risk by taking account of these variations in risk factors with age and, of course, their interaction with other risk factors. Those meta-analyses were conducted really from around 2000 until 2006, 2007. And they identified from multinational cohorts a small number of risk factors that impacted on fracture risk, at least partially independent of bone mineral density. So age, of course, is not shown on the slide here, but age is a major risk factor for fracture, and on this slide for hip fracture in particular. But you can see that we have risk factors ranging from prior fracture on the left to rheumatoid arthritis on the right. In the grey bars, we're looking at the gradient of risk for the presence of each of those risk factors. And in the orange bars, we've adjusted for bone mineral density. And as designed, we selected risk factors that were largely independent of bone mineral density because we could then usefully combine these, and they would remain significant contributors to future fracture risk. And it was that combination that led us to the FRAX tool. So the FRAX tool itself was launched in 2008. We're very pleased to have a large number of country models from around the world, and this is just an example from the Kingdom of Saudi Arabia model that we put online a few years ago. And you can see that the tool itself is a very simple one. It just requires risk factors such as age, sex, height, weight to allow us to calculate BMI, and then simple dichotomous questions about previous fracture, parental hip fracture, glucocorticoids, and so on. These risk factors could be used in the absence or presence of bone mineral density. In this example, the bone mineral density has been entered with a t-score of -3.7, and you can see that that gives a major osteoporotic fracture risk of 20 and a hip fracture risk of 4.2. Of course, we recognize that like all tools that we use in clinical practice, there are limitations to FRAX. Some of those limitations are listed on the slide here. For example, it doesn't accommodate all the known risk factors. So it doesn't include falls as a discrete risk variable. It doesn't include other skeletal measures such as biochemical markers of bone turnover or quantitative ultrasound. Even for the risk factors that we have in there, more detail could be inquired about. So, for example, we don't have a dose response for the effects of glucocorticoids. We don't have a dose response for the amount of smoking. And we don't have a dose response for the number of prior fractures, for example. Again, the tool will depend on the adequacy of epidemiological information, not just for the epidemiology that allowed us to build the FRAX tool, but the output of FRAX is calibrated to each individual country, and that's calibrated on the basis of epidemiology of at least hip fracture risk and age-specific mortality rates. That allows us to have the outputs of 10-year major osteoporotic fracture probability and 10-year hip fracture probability. So we're always looking out for improvements in the epidemiological data for those variables. This is a relatively old slide, and we've got limited country models available, but that's steadily decreasing in number. And the bottom line, of course, is that it's a tool, it's an aid to management, but it doesn't replace clinical judgment because no single tool will know as much about the patient as we do having the patient sitting in front of us in clinic. And we've talked about limitations of FRAX, but of course we should recognize that all the tools that we use in clinical practice have limitations. So if we just base all our decision making on bone mineral density, then of course that doesn't accommodate all the known risk factors. We would be ignoring the impact of age, prior fractures, glucocorticoids, and so on. It lacks detail, and some centres will just look at the report of the scan that comes back, and that report may be generated by different individuals with different skill levels who might misinterpret some of the findings from the scan. Again, even there, where we're comparing bone mineral density to normal for a normal range for age and sex, that depends on the adequacy of the epidemiological information, and so on. So recognizing that there are limitations in FRAX, we have been giving some thoughts as to how we might improve FRAX in the future. And this can really be looked at in a number of ways. Can we modify the existing risk factors? So I mentioned dose of glucocorticoids, number of prior fractures, and so on. Can we add in additional skeletal measures? Well, we've already had an adjustment for several years for trabecular bone score, but we're often asked questions about what do we do in the presence of a discordance between T-scores at the femoral neck and T-scores at the lumbar spine. So how can we accommodate that? Other physical measures such as hip axis length and so on. And is there a possibility of actually including new variables that are associated with increased fracture risk? And the most obvious of these being falls, but other causes of secondary osteoporosis and increased risk of fracture risk, such as diabetes, both type 1 and type 2 diabetes. Can we incorporate those into future iterations of the FRAX tool? So some years ago, using data from the UK, we were able to come up with an adjustment for the impact of dose of glucocorticoids on the 10-year probability of fracture. And this is just looking at some outputs in men and in women. And on the left two groups of the graphs here, we're looking in the absence of information about bone mineral density. But using adjustments derived, as I say, from the CPRD database in the UK, we were able to look at the impact of a low dose exposure of glucocorticoids, a medium dose of glucocorticoids, and higher in this case being greater than 7.5 milligrams of prednisolone daily or equivalent. And you can see that impact again interacts with bone mineral density. And you can see that the medium dose and the higher dose gives greater increases when the T-score is low than it does when the T-score is not known. So that adjustment's been around for a few years, but it's derived from one country, from one study, and that's just one of the limitations that we have to recognize about the nature of this adjustment. More recently, there's been a great deal of talk about the impact of recency of fracture on fracture risk, and we know that, as we can see on both graphs here, that if you're going to refracture after a recent fracture, then the risk of that fracture is particularly high in the first couple of years after that sentinel fracture. And the same is true for hip fractures as it is for forearm, spine, and humerus fractures, and indeed it's true for other fractures, although the gradient of risk, the hazard ratio shown on the right here, is somewhat lower for some types of fractures, such as forearm in this example, compared to spine fractures at the other end of the spectrum. So can we derive adjustment factors for the recency of fracture? The answer is yes, we can, but it's a bit more complex than just one single number that can be applied to the adjustment. That's illustrated here on this slide. This is looking just in women. And in these women, we have been looking at recent vertebral fractures on the x-axis, recent hip fractures, recent humeral fractures, recent forearm fractures. And you can see that these recent fractures are associated with multipliers that can be applied to the FRAX output for a fracture occurring at any time in the past. But these multipliers are somewhat complex. So you can see, for example, that there's an age interaction. The multipliers are much higher at younger ages, around the age of 50, than they are around the age of 90. And they differ across the forearm types, as we saw from the previous graphs. The forearm has a much smaller impact on the increased risk of fracture in the near future than a vertebral fracture, for example. So it's complex, and that makes it a little bit difficult to incorporate into easily applied algorithms. That was for women. This is just looking at women and men with a recent spine fracture in the two groups on the left, recent hip fracture in the two groups on the right. And you can see that for recent hip fracture, the multipliers are relatively similar in men and women, but for spine fracture, the multipliers are somewhat lower in men and women. And again, that can be applied, but not easily applied without really putting this into computer algorithms. So what we've been working on over the last couple of years is adjustments to FRAX, and this is a program that we are now terming FRAX+, that allows the individual clinician to try to define the fracture risk a little bit more detailed by adding in additional information. And this diagram just really shows the flow chart of how that would go about. So on the left here, we would undertake the normal FRAX assessment, input the usual FRAX variables, do the calculation, and then get the original FRAX result. But you then have an option. Do you want to adjust this FRAX value? And in this example, the clinician has decided to adjust for the recent fracture, for a recent fracture within the last 2 years. And then they have 2 more questions to answer. What's the site of that fracture, and roughly how long ago was that fracture over the last 2 years? Then the program itself takes the original FRAX result and multiplies it by the multiplier that applies for that particular patient's age, bone mineral density, gender, fracture site, and so on. And that gives you an updated, adjusted result. So, as I mentioned, this is termed FRAX+, and we hope to launch this in the next couple of months. At the same time, we're just updating the FRAX interface. So this is the FRAX model, exactly as it's constituted at the moment. You're entering the age or the date of birth, the sex of the individual, the weight and height. The previous fractures and other risk factors are yes or no variables. Again, you've got the option of putting in the femoral neck T-score and to calculate the risk. And in this 65-year-old woman with a BMI of 25 and a previous fracture and a current smoking history, then she has a 10-year probability of 18% of major osteoporotic fracture and a 5.4% of hip fracture. And then you can see in the green bar here, you can adjust your results by using FRAX+. When you come through to the FRAX+ web page, then you'll be offered a number of adjustments that can occur. This slide is slightly out of date now. We've got about another 3 adjustments that can be made. You can see from the slide here that we can adjust for the recency of fracture. We could adjust for the dose of oral glucocorticoids if we had ticked the glucocorticoid variable in the FRAX page. We can adjust according to the TBS value. We can adjust according to the duration of diabetes. We can adjust according to the number of prior falls in the year preceding the appointment. We can adjust for hip axis length. We can adjust for lumbar spine, femoral neck discordance, and so on. And that's something that we'll continue to work on over the next few years. In this case, because this woman had a recent fracture, we can answer further details, and it was a humeral fracture about 12 to 24 months ago, and then we can click on adjusting the probability. You then get an output page which has all the original FRAX risk factors and the answers to the data that was inputted to the FRAX calculation. And then down on the bottom here, you can see that the probability has now been adjusted according to a recent fracture. That previous fracture was a humeral fracture 12 to 24 months ago. And on the bottom right, we have the impact displayed for how that changes the FRAX outputs. This lady previously had a major osteoporotic fracture probability of 18%. And because of her recent humeral fracture, that has now increased to 28%. Previous hip fracture probability was 5.4%, and because of that humeral fracture, that has now increased to 8.1%. So that's a development that's coming in the relatively near future that will allow us to make more refined adjustments for some of the existing risk factors within FRAX and some of the risk factors that we can readily access within our current clinical practice related to FRAX. And that just leaves us a question about FRAX itself. FRAX, the original FRAX, as I mentioned, was launched in 2008. It was largely built from a cohort of patients from a relatively small number of international cohorts. You can see that we had just over 45,000 individuals in those original cohorts, with just under 200,000 patient years of follow-up. We're in the process of building what we've called FRAX2 for the time being. Over the last 3 years, we've just been collating all that data together, and you can see that we have 64 cohorts now as opposed to 9. We have over 2 million men and women in the databases, and approximately 20 million patient years of person years of follow-up. As you can see, that the number of fractures that we have to build the model on that will increase the granularity of the model. In the original development, we only had 850 incident fractures, and now we've got over 42,000 incident fractures for hip fractures, and just under 200,000 fractures for all osteoporotic sites. So a lot of work is going on, and we hope that this will take probably another 2 to 3 years for completion, but it allows us to look at a lot of additional risk factors that we've been asked about, clinicians have asked about over the last 10 to 15 years. Of course, we've got to bear in mind that the tool is meant to be relatively simple to be used in clinical practice. So we've already set a high threshold for the inclusion of risk variables within the original FRAX, and we'll continue to set a high threshold to maximize the value added for inclusion of risk factors into the future iterations of the FRAX model. But some of those potential inclusions are shown here. To summarize this talk, FRAX is now a well-established clinical tool, widely used in the assessment of fracture risk, and in some of my later talks we'll talk about treatment decision making. It has limitations, similar to all clinical tools that we use, and we recognize those, and in the current situation we're trying to address those limitations as best we can. We can do that by modifying existing risk factors. We have to recognize that the level of evidence for those adjustments is less than for the FRAX variables themselves, because the FRAX variables themselves came from multiple international cohorts, whereas these adjustments often come from one cohort or a small number of cohorts rather than representing the whole globe. But we hope that the next generation of FRAX will be launched in the next 2 to 3 years, including novel and updated existing risk factors. Thank you very much, and I look forward to the questions and answers.